Hello and welcome back to Clinical Cases. Today we're going to be looking at the final 10 cases that we were taught about in the respiratory block. So these include lung cancer, pulmonary embolism, PCD, which is primary ciliary dyskinesia, COPD, pulmonary fibrosis, neonatal lung diseases such as bronchopulmonary dysplasia, respiratory distress syndrome, and chronic lung diseases of prematurity, pleurisy, drowning and secondary drowning, and interstitial lung disease. So let's get started with lung cancer. So it's a malignant lung tumour characterised by uncontrolled cell growth in tissues of the cell. So this growth can spread beyond the lungs, of course, by process of metastases, as all cancers can. And most cancers that start in the lung are known as carcinomas. So the two types of carcinomas are small cell lung carcinoma and non-small cell lung carcinoma. The common symptoms you'd expect with lung cancer are coughing, including hemoptysis, so coughing with blood, weight loss, shortness of breath, and chest pain. Now, the problem with symptoms for lung cancer is that they're so similar to the symptoms that present for so many other diseases in the respiratory block. So therefore, lung cancer is really quite hard to diagnose, especially in general practice. However, the causes of lung cancer we really need to be aware of are tobacco smoking. So around 85% to 90% of cases are caused by tobacco smoking. There's a direct link between the two. However, you could be aware of other contributing factors which may cause the remaining 10% of cases, such as genetics, asbestos exposure, air pollution, and secondary smoking. So, similar to many other cancers, lung cancer is initiated by activation of those oncogenes, or inactivation of a tumour suppressor gene. And a mutation in the KRAS proto-oncogene is responsible for around 10 to 30% of lung adenocarcinomas. So again, this is just a brief look at the different types of lung cancer. You need to be aware of it in much more detail. So you've got squamous cell carcinoma, these are the most common. Adenocarcinomas, so these are the least malignant, slow growing, but they're quite resistant to radio and chemotherapy. You've got small cell carcinomas, so these are fast growing, these are malignant, and the prognosis is absolutely awful for a small cell lung cancer. You can also have carcinoid lung cancer, which is quite rare, but it can be quite variable in malignancy. You could have a mild form or quite a severe form. However, most of these are benign. And you can also have alveolar cell carcinoma, and these are very rare. Good to know, however, it usually occurs in older people. It's quite uncommon in young people. However, it is still possible to occur in young people, and it causes around 40,000 deaths per year. So it's the biggest form of malignancy in terms of cancer diagnosis in the UK. It's not the most common, but it does cause an awful lot of deaths. So pulmonary embolism, moving on. It's good to be aware of key terms when thinking about pulmonary embolism, because you need to differentiate between a VTE, a DVT, and a PE. So venous thromboembolism is a blood clot that starts in a vein. Okay, so very simply, it's a blood clot in a vein. A deep vein thrombosis, so this is a clot in a deep vein. Usually it's in the leg, but sometimes it can be an arm or another vein. And a pulmonary embolism occurs when that DVT, that clot in a distal vein, breaks free from the vein wall and travels to the lungs and blocks up the pulmonary circulation. So the most likely for these to occur are blood clots that occur in the thigh. So symptoms of pulmonary embolism: the patient will be short of breath, will have chest pain, particularly on breathing in, and they'll be coughing up blood potentially as well. So signs, so always differentiate between symptoms and signs in terms of clinical diagnosis. So signs, you'd expect them to have low blood oxygen levels, rapid breathing, rapid heart rate, and mild fever. So in terms of diagnosis and investigations, be aware you do possibly a chest x-ray, ECG, ultrasound, you possibly do a D-dimer, and also you do an arterial blood gas, because remember you've just observed that there may be a low blood oxygen level, a rapid decrease in oxygen. So risk factors for pulmonary embolism, these really stem to this main cause here, which are long periods of inactivity. A lot of people tend to get them after bed rest or car or plane journeys, which are particularly long. Other causes, however, are older age, certain diseases which are associated with peripheral artery disease and cancer, smoking and obesity. It's really important to treat a pulmonary embolism quickly, because there are severe complications if not, so cardiac arrest, sudden death, shock, abnormal heart rhythms, and pulmonary infarction as well, so you can lose part of your lung in terms of death of part of a lung. So how would we treat a pulmonary embolism? It would come down to anticoagulants, so these prevent growth of current clots, but they also prevent the growth of new clots forming. And in severe cases as well, you may prescribe thromboembolic embolytic medicines, but these can cause bad bleeding, so you have to be careful in who you present these to. And lastly, you could produce a thrombolectomy, which is a removal of the clot surgically. It's quite minimally invasive. Or you could have a vena cava filter as well if you're unable to take anticoagulants. So PCD, this is primary ciliary dyskinesia, also referred to as cartilaginous syndrome. It's quite rare, and it causes a defect in the action of the cilia, which line the respiratory tract, both in the upper and lower. But also be aware that you've got cilia in other places as well, so in your fallopian tubes and your flagella of your sperm, and it can also affect those. It's inherited in an autosomal recessive manner, and what's really important is understand how your normal cilia work, then you understand what goes wrong in PCD. So in normal cilia, they're motile, in the respiratory tract, in the lungs, and in the middle of the ear. They've got a rhythmic waving and beating motion which works to keep the airway clear of mucus and dirt, which allows us to breathe quite easily and without any irritation. There's two genes that are directly implicated, so these are DNAI1 and DNAH5, which code for components of the dynein arm complex. Don't worry about that in too much detail. But essentially, it's a mutation in these genes which occurs in around 40% of patients with PCD. Clinically, they're going to have quite bad congestion, nasal obstruction in terms of mucosa. They'll probably be mouth breathing. They might have inflammation of the tympanic membrane, because remember you've got cilia in your middle ear as well. You could have hearing loss, hypoxia, crackles and wheeze on examination. So just be aware of some clinical signs of PCD. But essentially the aim of this treatment is to prevent permanent lung damage and improve day-to-day function, and physiotherapy is quite a good way to do that. And as well, coughing's good, so encourage coughing because it gets up that mucus which is getting stuck in the lungs. So avoid medication as well that stops the coughing reflex. COPD is something else that we were taught about. So COPD, chronic obstructive pulmonary disease. So it's an obstructive lung disease characterised by long-term breathing problems and poor airflow. So it's progressive, obviously it worsens over time, and eventually even everyday activities such as walking or getting dressed become strenuous and difficult. So symptoms don't really appear until the damage becomes more severe. So you'd expect the symptoms to worsen over time. So shortness of breath, at first it's maybe minimal, but eventually you'll get shortness of breath just from walking or getting dressed. Other symptoms you may include wheezing, chest tightness, a chronic cough. It could be productive, but not in all cases. You may also notice edema, lack of energy, and unintended weight loss as well, particularly in those later stages of COPD. Causes really is linked to tobacco smoking, so that's the biggest cause of COPD, but you could also link it to occupational aspects such as fumes and dust, or genetic aspects in terms of a deficiency in the alpha-1 antitrypsin, which normally protects our lungs, but obviously if you've got a deficiency in it, you're more susceptible to diseases such as COPD. Also be aware of how we stage it, and treatment is essentially to slow down the disease progression, because we don't want it to progress any worse than what they have when they start. So quitting smoking and avoiding triggers such as air pollution are really good ways in terms of ways we can slow down that decreased disease progression. Moving on, you can look at pulmonary fibrosis. So this is basically a category of diseases which lead to interstitial lung damage, which we'll cover later on in this video. So essentially it's ultimately fibrosis and loss of elasticity of the lungs. So lungs really need to be elastic in order to allow us to inhale and exhale properly. And pulmonary fibrosis is characterised by that shortness of breath due to loss of elasticity of the lungs. So the lung tissue becomes thickened, stiff and scarred, which causes that inability to expand as well as it should, and therefore it's difficult to transfer oxygen into the bloodstream. Consequently, vital organs don't get the oxygen that they need in order to function. Symptoms, you'd expect them to have a dry cough, shortness of breath, lasting tiredness, weight loss, and potentially clubbing as well of the fingernails and fingertips and nails. So that's something that's quite characteristic of certain respiratory and cardiac diseases. Next, neonatal lung diseases. Now these have been covered in the foundation block before, so this is literally a quick summary of each one, because you can reference them back in the foundation block video. But respiratory distress syndrome, basically the lungs aren't fully developed. It's due to surfactant levels, so surfactant levels increase with gestational age. So a lack of surfactant is essentially what's causing RDS, and the babies that have RDS will have an increased respiratory rate, hypoxia, and respiratory failings. They've also got risk of long-term damage as well. So BPD, bronchopulmonary dysplasia, this is a chronic lung disease. and it occurs in those who are treated with supplemental oxygen at birth and they'll require long-term oxygen. So usually it does occur in patients who've had RDS in the past. And lastly, chronic lung diseases of prematurity. So this just refers to diseases such as RDS, BPD. Babies essentially that need a mechanical ventilator and extra oxygen for breathing. It usually occurs in premature babies, or babies that are essentially fragile or easily damaged through birth processes. So it's usually linked to these four main things: so prematurity, low amounts of surfactant, oxygen use, and mechanical ventilation are the main triggers for a lung disease of prematurity. Pleurisy is something else that we looked at. So this is inflammation of the pleura. So remember, pleura are those two layers that surround the lungs. You've got the parietal and the visceral pleura. Be aware that pleurisy is inflammation of that. It's associated with accumulation of fluid as well. So sometimes you can get a pleurisy and pleural effusion simultaneously. Causes, of course, are infections, TB, congestive heart failure, cancer, PE. Symptoms, you'd expect pain in the chest, again, which is made worse on breathing in, shortness of breath, local tenderness, and patients may also have some shoulder pain or back pain as well. Diagnose it from a careful history, and as well findings on examination of the chest. As well, of course, if it's accompanied by a pleural effusion, this will be seen on a chest x-ray or an ultrasound in emergency care. So, the only other thing to mention here is the innervation of the pleura. So be aware that the parietal pleura is innervated by the intercostal nerves and the phrenic nerve. The costal pleura, diaphragmatic pleura, and mediastinal portions are ways of categorizing the pleura based on their location, and they've all got a different nerve supply, so be aware of kind of what nerves are affected in what area. Drowning and secondary drowning. This is something that hasn't been covered in lectures, but essentially is very relevant to respiratory block. You might see it very occasionally on the wards on your rounds. So drowning is death by suffocation due to being submerged in the water and inhaling water into the lungs. But a good thing to be aware of is dry drowning and secondary drowning. And it's more something to be aware of, not for your exams or anything in that respect, but just to be aware of it. So dry drowning is when water never actually reaches the lungs, but instead breathing in water causes the vocal cords to spasm, and therefore it's actually a delayed effect of drowning. So secondary drowning is where your airway opens up, letting water into the lungs, where it builds up, so pulmonary edema, and then later on it occurs within 1 to 24 hours of the incident, the secondary drown. So symptoms of drowning, very obvious really: coughing, chest pain, but also they may be unconscious if they've drowned significantly. But treatment really stems to immediate treatment at the scene, so CPR, but be aware that they may vomit or back the water that they've swallowed when drowning. Also, drowning tends to occur in younger children, so 1/5 of cases are in children under 14, so it's quite a high proportion. So really, prevention is keeping an eye on your children, because young children can drown in really minimal amounts of water. Lastly, to cover is interstitial lung disease. So this again is a group of lung diseases which affect the interstitium. So this is the tissue and the space around the air sacs of the lungs. So it concerns the alveolar epithelium, the pulmonary capillary endothelium, the basement membrane, perivascular and perilymphatic tissue. So basically all that tissue which is associated with the alveoli. So it usually occurs when an injury to the lungs triggers abnormal healing responses. So normally the body will issue tissue to repair the damage that's occurred, but in interstitial lung disease you'll get an overprocessed, really. You get too much tissue to repair it, and it causes scarring and thickening of the alveoli, which makes it difficult for that oxygen to pass into the bloodstream. So this is quite common. A few of the diseases we've talked about are linked to interstitial lung disease, because essentially it's that difficulty getting oxygen into the bloodstream and to your vital organs. So you can classify interstitial lung disease by cause, and symptoms really are shortness of breath and dry cough. Be aware of complications as well, so pulmonary hypertension, right-sided heart failure and respiratory failure. So we've covered respiratory failure. Pulmonary hypertension is something to be really quite useful, be aware of as well. So it begins when scar tissue or low oxygen levels restrict the smallest vessels, limiting blood flow in the lungs. So it's basically hypertension of the lungs, the blood vessels in the lungs. So blood pressure in the lungs should be lower than that of the normal blood pressure anyway in the body. So hypertension obviously is increasing that pressure. That is everything for the respiratory block. As always, if you've got any feedback, please do leave it below in the comments, or feel free to message me personally. And continue to be aware that this isn't revision for your exam, it's more just a brief whistle-stop tour of all the clinical cases that we're taught about. Thank you very much.